All right. So yes, thanks for having us. This is the um, Locum Tenens, Pearls, and Pitfalls section. And Raj Patel is a board member of the AAEM-Locum group. I'm the chief medical officer of that. Rob Moore was hopefully going to join us as the president, but got pulled in to cover for a sick colleague. So briefly, the AAEM-Locum group was created kind of as an outshoot of a Facebook group that another doc had created called Locum's Transparency, because ultimately when you jump into the world of locum, it's like you really have no idea what you're getting into. They don't train us for it, and there are plenty of people who will take advantage of you and try to charge the most to a hospital system or group, and then the least to you, and then often a bit of bait and switch that goes into it. Then you might walk into a hospital where you are apparently covering the entire hospital and also delivering a bunch of babies at the front door. And if you don't really know that of what you're getting into, you can put your license at risk, and you can be taken advantage of. So plenty of unscrupulous groups, and there's lots of ways to do locums, which just stands for placeholder. You know, you can go directly to a hospital, you can go directly to a private group, or you can go through a intermediary like a locum company, or you can go do what you kind of think is locums, but really it's an internal traveler for one of the contract management groups, or you work through one of their intermediaries that is locums, but for one of these CMGs. So there's a million different ways to do it, and I'll let Raj kind of jump in, give his background, and we'll get this rolling, and then I think just kind of riff off each other. And Anna, feel free to jump in if you have questions verbally or in the chat.
Sure. So thanks, Mitch. I did most of my schooling education in New York. I did my residency at Sinai in Manhattan. Had ridiculous amount of debt, so I picked up and moved to Dallas, Texas, and that was my first job there. At that point, I branched out and started doing a lot of, I guess, could be defined as locums work and freestanding ERs in the greater Dallas area. I drive a couple hours out. And then since 2017, I graduated in 2014. So 2017, I've been pretty much almost exclusively locums doc, or doing like locums, like per diem type work. And we can go to the differences of that also later. And then I, for a while, was the medical director of a staffing company, which I exited December of last year. And now I serve on the board with Mitch, and we do that. And I do still currently 1 week of locums, and I do per diem work and locums back in New York, which is where I'm based out of. I live. My locums work is in the Midwest, Wisconsin. So
thanks. Yeah. Sorry, I'm trying to get, there's one group workshop that doesn't have its people, so I'm trying to.
That's okay. I can start off. So, generally from locums work, what I've figured out or what I've seen is that places that need locums docs are one of two versions. Usually it's either hospitals or places that are difficult to get to. So rural locations where you have to like land at a hospital, you land at a local regional airport and you drive an hour or whatever, and the hospital is just difficult, situated in a hard place, but the culture is pretty good. Those places generally have a lot of locums need. The second place that generally has a lot of locums need are toxic culture places. So a lot of places that just have poor management, and the culture is just, they just can't retain physicians because people don't want to stay there long term. I think in each of those scenarios, there's pluses and minuses, depending on where you live and the travel availability and stuff. So like I live in New York, I have 3 major international airports to get to anywhere in the planet, pretty much. If I live somewhere, maybe like, so I'm in Wisconsin right now, and there's not as many airports, a lot of smaller regional airports. So travel, depending on I guess everybody has their own decision tree about what they're tolerate and what they won't tolerate. So culture is always a catchy one, because that's where the locums work really comes into your contract and all the things that you define before you walk into the hospital in the first place, because you need to set up a situation where you're protected or you have an out to protect yourself and protect your license, because this is the thing you work 10 years for. I think in AAEM, in the locums group, we've developed best practices, and a lot of it comes down to transparency and the things that we've been reiterating along the way about, like, what type of malpractice are you getting? Do you get claims made versus like occurrence-based or claims plus tail? Do you have a what are the buyout provisions as a locums doc? So if you're a locums doc and let's say you sign on to work at a hospital and you love it there and they love you, generally for that hospital to employ you full time, they have to pay the locums company a certain fee. That fee can range anywhere from $5,000 to $50,000. If it's $50,000, you know, that could be a barrier to you getting employed. And I've been in, not personally, but I've had employees in different scenarios where the hospital want to buy them out, but the fee is too high. So financially, it doesn't make sense to just, makes more sense to rather pay them for another couple of years as a locum stock. And this is all kind of, I guess, depending on the company you work for, and you work usually with locums companies, there's recruiters, and recruiters you build a rapport with, and you learn that some you can trust and some you can't, and how they present you and the process. So we can kind of go through the process if that's what you guys want. Or in terms of selecting a site, it's really just regional and local about who controls the staffing of the area and the region. So like right now, currently I know there's like needs in Kentucky, and then obviously in the COVID regions, they always they're having emergent need right now too. The biggest locums corporate companies are probably Weatherby and Comp Health, I think. I would advise to stay away from them. The way the locums companies basically build a hospital is that, let's say your said hospital, locums company will charge them an hourly rate, and then their goal is to pay you, the physician, as low as possible, because their margin is the difference between what they receive and what they pay you. So they're the gamut of companies, some that are very transparent, and so transparency is always going to come back to it. They'll tell you their rate, they'll tell you their markup, they'll tell you how much they're getting versus how much they're taking and how much they're paying you. With AAEM-LG, the group, locums group, Mitch and I work on, we're trying to partner with and in working with the locums companies that we feel exhibit the principles of true, honest practice, and where that are not manipulative and not taking advantage of the physicians. So that was one of the reasons for the founding of the group. And
yeah, I can
say.
Uh-oh. Somebody froze again. Okay, there we go. Yeah, no, I can jump in from there. I mean, Raj has it right about the, it really, all this does come down to transparency in all of these fields. And for the most part, the locums market, when Raj mentioned Weatherby and Comp Health, pretty sure those are exactly the same company. I double check that, but I think those are all under one umbrella.
Yeah, they're in the same umbrella. Yeah.
So it's very similar to the CMG market. I mean, it's all just being consolidated. I think they have like 30 to 40% of the locums market. And as Raj mentioned, if you just get, I'm going to bring this back a little bit to how most people are brought into locums, which is you get an email from a recruiter and they have a, 30,000 visit ER in this area, and it's unicorn farts and happiness, and you'll make this kind of money, and you get a very short amount of information, and then they say, send me your CV. And the thing here is that that job may not exist at all. The recruiter could be fishing for your CV, which we'll get to in a minute as to why your CV is important. Now, when you're looking in, when you're in high school, you're told to have a good work ethic, just get your CV out everywhere, and pepper it out there. That actually can work to your disadvantage in this case. because you might be claimed. They're also just fishing for information. They want a Rolodex of physicians to use. Now, in a big corporate structure like Compelt or Weatherby, the recruiters, they really vary in sort of quality and just their own personality and integrity, but they're all working under the same corporate structure. And that corporate structure generally says you must get X margin or you're fired. You can't like get less than X margin. And I believe with Comp Health, I just had a recruiter tell me this. It's like $30. It's the minimum that they can take over what you are making in the ER. So they're not aiming for 30. That's the sad end of what they'll take. They're aiming for 70 or $100 an hour. So they're generally you're going to get very lowballed with your offers. So there's a bunch of pitfalls that you can run into. For one, if you just get a recruiter who is acting more like a dirty car salesman, then they can come off as really sleazy or they can be very personable and try to get you into a place and oversell the actual location. So they might not give you all the details. They're going to leave out some obvious things because, as Raj said, there's usually a reason they need locums. Sometimes it's just location. Sometimes it's just out in the middle of nowhere. And otherwise really nice, happy nursing staff or something like that. But for the most part, there's something going wrong. And maybe there was a mass exodus of physicians that were pissed off about something and you're really just a scab. Maybe it's SUMA and USACs just took over in a violent takeover and destroyed a residency program and you're going in there as a scab. Well, you don't really want that. And with AAEM-Locum group, we've really had good discussions with our partner, which is the ink is about drying on the contract, but we're really demanding true transparency as to what's billed and paid, not billed and paid in any name, but what the locum company is taking. And we've instilled and made sure that our partner is on the same page, that aiding and abetting like takeovers, which is what a lot of locums traveling sort of has become, for the bad guys is not something we want to be involved in. So we're looking at markets that are more like rural independent hospitals, even private groups that haven't traditionally used locums, or academic groups that might get stressed and somebody goes on maternity leave. I mean, that's really what sort of the ideal locums, in my mind, role is. So the difference, if you're dealing with a recruiter that is from a big corporate agency, is that you have to be aware that they might be just trying to get your CV and develop their Rolodex, and you're just their product. And by giving them your CV, you're allowing them to build sort of their base of information. But if they're particularly unscrupulous, they might take your CV and present it to all of the hospitals they know of. And they're kind of at that point lying and saying that you provided permission to give out your CV to those hospitals. And that essentially claims you as being presented. So that means if you go through a different locum company or you go directly to that hospital, you might be told, sorry, we did a name check and you're already presented. You can't work here unless you go through that company, which now has you, by the gonads, because now they can pay you whatever they want to, because that's your only option to get in there. The other issue for sure is it is like buying a car to some degree. And sometimes you're the lemon because they want the crappiest doctor to get the job. That's whoever's going to take the low ball rate. So you kind of have to know your worth and then market to them why you would be a good fit. And you have to watch out for them selling you a lemon, which is going to be the job, and finding out what the circumstances are really like. In AAEM-Locum group, we actually have our basically a worksheet, of a transparency worksheet, which is going to be what's billed and collected, what cut the locum company takes, and what the insurance situation is, and then even what we call like a risk spreadsheet of what the environment is like at the hospital, including like questions that you might want to ask, what specialty services are missing, what's the worst part about working at the hospital, transfer arrangements and things like that. If you're going for a general company, you really just have to ask these questions. But the challenge is, of course, if you ask all these questions and you get really annoying to them, then they'll might move on to somebody who's easier and asks fewer questions. So I'll stop right there, see if Raj has any thoughts, or if you guys have any questions in the audience.
Mitch, I have this like PowerPoint like that. It's a lecture I usually give to residents about jobs contracts, but it kind of goes into just understanding markets and stuff like that. I was trying to share it, but let me see if I can pull it up. But yeah, if anybody has any questions, how would you go about contacting facilities directly, large organizations versus small standalone facilities? So I found I've had varying experience with this. When I came out of residency, all of my attendings were like, "Oh, go and just call them directly, call them directly, call them directly." And what I've had very little success doing that initially. And what I found is that the reason hospitals or emergency like directors don't want to directly contract with individual physicians is because it doesn't there's no backup or support behind that one physician. So if they contract with a group, let's say any locums group, and let's say like I'm the physician and I go and I contract and I'm with going through a group and I show up at the hospital. If I don't show up, the group is accountable for providing a physician to that hospital and for that director for that shift. And so contacting facilities directly has not been very successful for me. However, that being said, I am currently employed in an internal locums position. And so it depends on if they have positions like that. It's becoming, I think, locums as an industry and as a job lifestyle is growing. And so more and more hospitals and more systems are becoming um, acquainted with it and accepting it and internalizing it rather than paying these like middlemen higher rates to just bring the same doctor over. Small standalone facilities, I honestly just email or I would pick up the phone and just call the director or email the director and be like, hey, do you guys need coverage? What coverage do you need? And then see what they do. I always tell my residents when they're looking for jobs, I said, you need to offer them. Everything's about need, right? What does a system need? And what is the hardest shift to staff? If you ask any director what the hardest shift to staff, it's weekend nights. Get a Saturday night shift covered. That's the hardest shift to staff. So for me, I'm a night doc, so I get a lot of leverage in terms of when I apply for jobs, even locum jobs, and they're like, oh, you're a night doc. Okay. So I can ask for a premium. I can ask for better scheduling. And they'd rather take me over another doc who's like, no, I only do days. The great thing about locums is you make your schedule. You have full autonomy, which is what I love about doing locums, is that I very honestly work one weekend a month, and I've worked 0 holidays in the last 3 years, unless they pay me. And then with locums, most of the time you get holiday rate, which is time and a half. So if you work time and a half, so the pay is better and the schedule is better. I think there are a lot of benefits to it. It's just a matter of finding the right fit for you, and then also make sure you're not in a situation that endangers your license, because that's what we work for in our livelihood. Any other questions? You guys can type it there.
I'll add to what Raj said about, so contacting facilities directly is a big question. We think we want to cut out the middleman, and that's usually the right thing in almost everything, is to cut out the middleman. But then sometimes you find that the hospital wants that middleman, or somebody wants them to outsource so that a group will take care of their staffing needs. So you might be able to go directly. And I will say that in my locums career, I've gone through one of the Medicus, which is one of the bigger firms, still pretty corporate, felt pretty dirty car salesman. Not a great experience, but they paid on time, they were organized, but still that negotiating stuff was no good. And then I've gone directly to a small private group. So that I went directly to that group, and that worked out. And that was through just word of mouth. There's one other hospital that I feel like I've almost gone, Tony, forget his last name right now, but there's a medical director of a small private hospital. And honestly, they just pushed me back to the locums group because in order to get some of the paperwork done and make sure you're an independent contractor, the hospital didn't really have that mechanism for it. So it's definitely doable. And if Rob was here, I think he's had more experience doing that. But sometimes you actually have probably more negotiating power in a way by giving it to somebody who's been doing that for quite a while. And that's where I think somewhere in like Burlington Healthcare Providers, which is what we've partnered with after an RFP, can be somewhat valuable there because they know how to open those doors without you having to do it individually by yourself. I think I don't know if you have any other thoughts on that, Raj. I think if you were to like call up the ER, you could talk to some docs and honestly get like an inside picture of at least what's going on there. If they're not,
I've cold called on behalf of residents and myself a bunch of ERs and just talk to the docs and seeing if they have openings, see what the culture is. A recruiter can be worth their weight in gold. I mean, there was a company, I don't think it exists anymore. When I moved from Dallas back to New York, and my recruiter was phenomenal. I mean, I was the highest paid locums doc in the hospital, and she just went to bat for me. And I even had like a medical calamity, and she was able to cover everything without penalizing me in any way because she knew I was a good doc, and I'd earned a lot of money for the company and for her. So a good recruiter, if you find one that, has integrity, can actually take you very far, and you guys can have a very nice relationship and develop and, work together to basically earn together. But I would say that the majority of recruiters that I've encountered are generally college grads that are like 23 years old and just fell into this job because it's in the job market, and they don't really know anything about anything, and they're not savvy about negotiating. Most physicians are not aggressive negotiators. And I would say when I was medical director of my own staffing company, I took it on our company to do a lot of the negotiating, which was me and the founder, the CEO, because physicians generally under negotiate. And for me, I didn't want physicians to be underpaid and taken advantage of. I mean, knowing your value is one of the most critical things, I think, as a physician in any type of job situation, is knowing how much, like, what are you worth? What are you worth? And it fluctuates, right? Like during post-pandemic New York, when the peak had hit and basically all the ER volume had dried up and there are no jobs anywhere, then you're now, the supply demand just kind of dictates. But in current situation where the demand is just climbing daily, the acuity is higher, hospitals are hurting. They need to staff back up, and there a lot of docs that were there are not there anymore, or they're just not working as much. I mean, pre-pandemic, I was probably doing 18 shifts a month, and even I've scaled back. I know Mitch has scaled back to work on this. So it's really understanding your value and knowing how to negotiate for your value, and knowing what the hospital system needs and wants from you. Some of them, do they need nights? Do they need days? Do they need weekends? Do they need holidays? Is there someone out in maternity? Are they covering for maternity and things like that? And then once you understand that and you get past the initial phase of, okay, I got a recruiter, there's a site, it's real. You give them your CV, they present your CV, the site says, yes, we like this person, please let's move forward. And then you go through the process and the rigmarole, but then you need to understand, okay, what's going on at this site? What's the volume? What's the coverage there? How many patients are you expected? Like, do you have, what are your nurses carrying? Are your nurses carrying, I'm used to in New York anywhere from 12 to 16 patients per nurse. And then I come out to Texas and it's down to like 4 to 8, what are you comfortable with? What is your backup services? OB, do you have surgery? Do you have this? Do you have vascular? Do you have urology? Or are you expected to do all of that? And then where do your transfer protocols? Understanding the situation you walk into is probably one of the most important things you can do as a locums doc, because what you don't want to happen is you have no understanding. You walk into a hospital and it is a toxic culture with no support, and the ER is maligned, and you end up in a bad situation with a patient where you can't get anything done and you can't do right by the patient. and a bad outcome happens. And seen it happen, so you need to be aware of what you're walking into. And it's simple as now with Facebook, I mean, just go on EM.doc or one of these 30,000 listservs and just be like, hey, does anybody know about this hospital? Or even, you know, on AM or Locums group, I'm sure somebody has some commentary on it. Mitch?
Yeah, it's something that we've even brought up, right, in AMLG. Like if we can get it's been brought up a few times about getting some transparent ratings of the hospitals and the jobs that could be trustable. And we're not quite there yet, but it's definitely something you can ask around about. You get a little bit of the inside dirt on these hospitals.
I mean, it's generally out there, right? You know, in any hospital system, if you call the docs, most, especially, I think night docs are just more open because there's no admin around, so they can kind of be free to say whatever they want. So if you call around like 9 p.m. or 10 p.m. and you talk to, just be like, hey, I'm thinking about coming on there, whatever, blah, blah, blah. Are you happy? You know, what are the issues? Would you stay there? Are you leaving? Turnover is a big indicator of a poor work culture and poor situation. If you, like Mitch mentioned earlier, if you see if there's a hospital that just lost 20 docs, there's a reason 20 docs walk out. And it's not just because, you know, they're not getting their CAT scans on time. Like there's something serious going on. I would say I'm a little bit more capitalistic than Mitch. I think like in that scenario, you pay me $800 an hour, I'll show up to a shift. I mean, you know, I'm all about fleecing these companies for all their money. I'll take as much as I mean, that's what, you know, it's a little bit of a business. The thing you have to understand, this is a business transaction. There's no loyalty in the game. The locums company is there to make money. You're there to make money. The hospital is there for you to work for them because they need someone to work in that shift. And the second that you mess up or you're not, or something goes wrong, I don't know how, you know, depending on the scenario, there's not a lot of loyalty to locums docs. I've been locums at one hospital for 4 years and they furloughed me the first chance they got because because as a locums, you're the highest paid asset. And so they're trying to cut their bottom line. So you're always on the chopping block. That's just how the finances work. So you better just be ready to know that. And you need to know what the contract termination clauses are when you sign a contract. For me, one of them, most of the time, I think is a 30-day contract clause, which means if they cancel your shifts within 30 days, they have to pay you that money regardless. But after 30 days, they don't owe you anything.
And sometimes that contract negotiation or termination clause is like, we actually had this with BHP, that you can be terminated. It has to be a 30-day notice unless the physician is found to be quote unquote unsuitable, which has a completely broad definition. So if you're worried about due process, you know, like locums is definitely not where you get your due process, because as an independent contractor, you're almost by definition signing it away. Now, as far as rates go, and this is an interesting thing to discuss in general, when Raj says he's capitalistic, I mean, you know, so how do we look at this, right? If Team Health wants a doc, I mean, I might be completely blacklisted from them. I have no idea. I haven't really tried, but if I try to go work for Team Health, yeah, I guess I would take $1,000 an hour. I mean, if they're kick them while they're down, I don't really care, right? Let me get that money. But you know, we're also driving up the cost of healthcare in general. I don't know. I don't feel bad there. I would feel bad if I were a scab over at SUMA. So USAC's destroying a residency program and then having me go there. And I've talked to docs there that have made $1,000 an hour, and they're like, I felt dirty. Like I just felt like a dirty piece of shit the entire time. And I just couldn't do that really myself. But a hospital that Team Health took over and now they're desperate. Yeah, I mean, I can't fault anyone for doing that. What I'd love to see, and we'd love to see AAEM-Locum group become, is the internal travelers for the good guys. You know, let's relieve our colleagues when somebody's on maternity leave or has an unexpected illness or an unexpected death in the family, and really be able to help out with AAEM physician groups that are equitable and democratic, and then we don't feel like we need to just screw someone else back. But you should be, as far as rates, what you really should be looking for, aside from being really aggressive and jumping on the highest rate you can get, waiting last minute until the hospitals or the recruiter's super desperate, and then you know, raising your offer or something. That's one way to look at it. But from a fair pay, you want to know that, of course, as an independent contractor, if you're not employed, you're not getting benefits. So there should be some increase in wage there. We're also very market responsive. So when the market is being flooded right now and we're being replaced by nurse practitioners, and we are getting more and more grads coming out, our market value will potentially go down. It's also going to be very regional. Your market value might be quite high regionally. But I think Raj says, I think rates are coming back up. I think that's true. There's going to be at least a temporary bump there, and we'll put some real numbers to it.
So I've read two conflicting things, right? The ACEP study that came out about the workforce really put a damper on the future of our profession and our field and everything like that. But I've read other consulting study groups about the healthcare workforce and how the demand is actually still going to outpace whatever we come up with. It's not, the numbers are a little bit harder to ascertain, to be honest. What I'm watching right now is the rates of pre-COVID. We're not close to that. And I'll put real numbers on it. So pre-COVID, you could find $300 an hour plus rates. I mean, that, I think they were there, they were out there. You just had to find them. Finding that right now is really difficult. I don't think, I know a couple docs doing it, but where they are and stuff like that, but very few. I think the numbers, but it's slowly climbing back. And I'm watching as the volume comes back in many hospitals where the demand is higher, the acuity is higher for all the delayed care that hasn't happened in a year. Maybe that's a small bump. I don't know what the long term is going to hold. In terms of supervising NPs and PAs, I've worked at a facility, and I had a smart phrase for my epic that basically said that I had nothing to do with this patient's care, and as per the hospital policy, I'm signing this chart, or I'm on this chart. I've talked to many attorneys. All of them have told me the same exact thing. It does not protect you. But at the end of the day, I'm a little bit curious about how, I always picture things as like, what do you do if you're in a court of law? If you're sitting on the stand and the lawyer says, why did you sign this chart? And you say, well, that's what they expect me to do for the job, so I had to do it. And it's like, did you see this patient? It's like, no, I have no idea about anything about this patient. What's your culpability and your liability? I can't imagine it's going to be as much and when I've read about case studies, they never get paid out the way it would have been paid out if you were actually involved. That being said, every lawyer's told me that those smart phrases don't necessarily protect you. You can always say no. I mean, the power to say no is the greatest power we have. I mean, if you don't like a job, you can walk away. I've said no. I had a job offer it was a freestanding ER that went up in New Jersey, and the reported rate to me was something like $285 or $300 an hour, which in New Jersey is insane. You're not going to get rates like that. And so when the contract showed up in my email, the rate on the contract was $185 an hour. And I called the director, who was a buddy, and I was like, hey, you told me the rate is like $115 more. And he's like, oh yeah, that's just the rate that I'm authorized to give, but I can't put it in writing. So I didn't take the job because honestly, at the end of the day, if it's not in writing, there's nothing holding accountability. There's no accountability to it. It has to get whatever, if there's something that is make it or break it, make sure it is on paper in writing, because they can pull the rug anytime they want. The NPPAs, sorry,
Okay.
Mitch. Now I was just gonna say the NPPA encroachment, we're fighting it. I mean, I just struggle. Like, I work in critical access hospitals, and I just don't see, they're taking over in a lot of other fields and they are pushing us, but there's still a level where they can't take our job. And I firmly believe that. And I'm an optimist at heart. I know Dr. Bad is Dr. Patel from earlier said he's a pessimist at his baseline. I'm an optimist at my baseline. So I think the pendulum has to swing back. The pendulum has to swing. Like in the 80s, we had corporate raiders. In the 90s, Goldman Sachs was the bad guy. Then it was McKinsey and Company. And now it's private equity. And they'll break that up too. It's just inevitable. I mean, you can't control $3.5 trillion asset under management and expect no one to pay attention to you.
Well, yeah, it's interesting, Raj, when you put it that way. Yeah, I don't know if the pendulum's going to swing back without us pushing it back, but I guess that's what we're doing.
That's what we're doing.
More of a
Yeah.
pendulum swing. And so, yeah, to put that in perspective, when we're talking, so I'll back up the wages. I mean, I worked 250 to 300 over the past couple of years, and you have to put this in perspective sometimes because, Raj, if you work critical access, there is a variety of what critical access means, to be honest. But if you're looking at a site that has a visit, annual visits of under 5,000, I would go well under 300 if
Oh
it's
yeah.
well resourced, right? You get a 24-hour shift, bang out a few.
Commensurate pay. Yeah. I mean, I'm with you on the commensurate pay. Like you can't expect a place that makes less than 5,000 volume to pay you 300 an hour. But if it's 5,000 volume, you're going to be sleeping. It's a sleeper ER, so you go down to like 150, 180. Yeah. Sorry.
Yeah. So there is that component to keep in mind, especially if you've been somebody who's worked in a community hospital or a tertiary center your entire career. I mean, I started my residency was at St. John, Detroit. It's like one of the busiest hospitals in the state, like 150,000 annual visits, and our PD never wanted us to rotate anywhere else because we would see everything at that one hospital. And say, yes, but I want to see that stuff without every specialty service and with having to transfer patients. So I learned sort of school of hard knocks just on my own as an attending these critical access places. But there is that aspect to keep in mind. And with nurse practitioners and PAs, I honestly I've worked in a smaller hospital where there was probably like 2 hours overlap. I worked mostly nights. Community hospital, probably one of the worst poorly managed and poorly resourced hospitals, where you had like a gastroenterologist every third Thursday, but he doesn't do scopes. It's kind of like the only specialist you get every once in a while, and nobody really on call. And the tertiary center before COVID, the tertiary center that we would refer to, was always on hold or divert or whatever they would call it. And so we'd be holding, and of course in the hospital, there's a nurse practitioner that runs the ICU within EICU intensivists. So I'm up there doing lines and resuscitating people because the NP at least knew she didn't know what the heck she was doing. So she'd always call for help, thankfully. But I'm covering that from the ER, and we'd have patients that like have unstable angina or an NSTEMI, don't qualify for the cath lab. We don't have a cath lab there. So we'd be holding them in the ER because they won't accept them to be admitted into the hospital because there's no cath lab and they get transferred. So we're holding patients 3 or 4 days with tropes that are trending up. I'm like, I got to stop checking these tropes. This is just not looking good. But that was where I really got introduced to really bad nurse practitioners. And I would say the only saving grace is that like we were only at 2 hours overlap and she was the only other person there. So I could actually kind of keep a little eye on those patients.
Yeah.
And that's at least direct. So, that's something that in the AAEM-Locum group, with our partner, we have one partner right now. It's a 1-year exclusive partnership, but we're open to spreading this transparency to any groups that are out there. We hope that this pushes the market towards transparency as being the standard. But part of that is what is the real situation with supervising mid-levels? And we may not be able to change that, but this should be another thought as far as what is your risk tolerance? Are you, maybe that's going to raise how much I'm not going to take that risk without a bunch more money than you're giving me, even if it's unsafe. You get to decide, basically. Now, the last place I was at for 1.5 years. Not typical for locums. It was like stable locums, basically. And we had NPs on the other side, PAs. Actually, mostly the medical director was good. It was a very good medical director, all things considered. And really didn't hire nurse practitioners. There was one NP there who was known to be very good and humble nurse RN prior that was experienced, and they hired her. Otherwise, all PAs, and they did a pretty good job of vetting them. So I felt like most of them were pretty strong. But I'd still get charts a couple days later, and I'd see somebody given a milligram IM Dilaudid for abdominal pain, and then something in the MDM that said no imaging required, and they just discharge them out. They come back with like an acute abdomen. I'm like, what? How could you give a milligram of Dilaudid to somebody that you don't think needs imaging? Like, one of those things is not make sense. So they're pushed in the fast track to get them in and out, right? I mean, that's what we're talking about with all of this. So to be honest, I just started billing my time, and this may not work depending on where you are, but I started billing like 2 or 3 hours of time after the shift to read through all the PA charts, which most people don't do. And then I would refuse to sign any that had any issues. And then I would CC the medical director with issues and concerns. And then the NPs and PAs just stopped sending me charts, and they started sending them to all the other doctors.
So that I did the same thing. That you kind of find ways to work around it. So when I went to a site that I was expected to sign off on the charts, I told the NP, every patient you see, you have to present to me. And I was the only doc that made that caveat, and otherwise I wouldn't sign the chart. So at some point they just stop presenting to you because they don't want the hassle of it. So they just say, okay, I'll present to all the other docs. So I was like, and I'm not, if you're locums, you're not RVU based, so you don't care. So you know, I mean, so at the end of the day, they just presented all the patients. So I stopped getting charts that way. So you got to be clever in some of these ways to work around it. I think Brad has a question. Figure out what hospital a recruiter is recruiting for. Is a positive contact hospital to split the difference? Hospital's cost. Yeah, I mean, hey, man, it's a game, right? Like whenever I get a recruiting email and I know the area, I'll figure out what hospital it is, and I'll be like, oh, that's a hospital I'd work at or not. You can totally. You don't even need to split the cost with a recruiter. If you can get from the phishing email the hospital and you can you call them directly and get the job, who cares about the recruiter in the company? You don't need to split anything. Yeah, that's the rule. Never split the difference.
Yeah, you know, the toughest part again is if you go to the hospital directly, they still may not have a mechanism, or they may not want to, and you might have to get your own malpractice insurance. So if you're astute at that, or the hospital has a mechanism, then great. I mean, you can theoretically take a lead. It's like we want to be appropriate and ethical to the recruiters. The recruiter told me about the job. But like they're playing games with you too. So, you know, I would honestly probably bring it up to a good recruiter that I know potentially, you know. But you can definitely do your research on this. You have no obligation to the recruiter from Comp Health that's out, you know, out of college and just quit their car salesman job. Yes. Still making friends with the nurses. I mean, this is something that obviously keeping my mouth shut, I struggle with. Brad might understand with me, right? You are going to be walking into a situation potentially where there is discord. I mean, look at how the nurses right now, like the RNs that are all the traveler RNs are getting like treated better and getting paid way more. Yeah, and that's, I mean, there's some discussion that might be a union busting tactic. So the unionized nurses at the hospital that unionized are getting treated like crap to make them feel like it wasn't worth unionizing. And then they're throwing pizza parties for the travelers and saying, we love you, and spending more money. And it doesn't make sense why they would do that. But anyway, you might be walking into that situation as a doc, or and still you got to get to know the nurses and
nurses control these hospitals. I don't know, Mitch and yours, but in the locums world, you got to make friends with the nurses. They control the hospitals. They will, if they don't like you, you be ready for your contract to be terminated. That's a lot of the locums hospitals are run by the hospitals they keep their accreditation, they keep their stroke certification, they keep their STEMI certification, because the nurses activate and run it, because the docs are a revolving door. And so you got to play nice with the nurses. That's cardinal rule. I've seen a lot of docs come through hospitals just because the nurses are like, he's not here, we don't want him anymore, and they'll just push him out. They'll find ways.
Yeah, and that's, you know, that's a central issue in general with due process, that like nurses can just they hold that power. Even when you're advocating for patients, that can be a problem. So the thing is, in the locums world, you kind of have to go in knowing that that's sort of absolutely the case. So we don't want that. I don't think that's acceptable, you know, that nurses do have that power in general, but when you're in the locums world, you kind of have to know that that's like obviously how it's going to be, particularly making enemies in the first.
If I can just for a second, it's because a lot of the ones who are not traveling are there. They live there, their home's there. They know we're coming and going. If they want to be lazy, they're just going to be lazy. If they're going to sit there and let them be at 60/40 for 2 hours, that's just their culture there and what they're going to do. And yeah, coming in with your best practice of medicine on your sleeve, it can be super challenging.
Yeah, definitely. It's just really just, I mean, like I said, a lot of the locums places, there are two reasons the places have locums. They're hard to get to or they're hard to staff because the culture is really toxic. So I think we got like, what, 10 more minutes, Mitch?
Yeah, feel free, guys, if you guys have questions, jump in, talk out loud or type it. Raj, I have to do something technical here for 1 second.
Sure.
And then
No
we
problem.
can always, end this. I'm gonna 5 minutes early so I can go around the restroom before we get back to the whole thing. But
No problem. Does anybody have any questions off the bat or comments, thoughts? I mean, I've worked in 5 different states, six different states, 16 different jobs, different small groups, physician-led groups, corporate groups, big locums, small locums, DNY, team health, and vision. I mean, I've pretty much run the gamut. Big academic. I've done difference. Between part-time, between per diem and locums, pretty much comes down to who pays your malpractice. So I do work per diem at my residency site at Sinai, and they pay my malpractice. Locums, the locums company pays it. It's another avenue to go to wherever you're located or based out of. And I think those are most. We've covered a lot of the ground. You guys have any questions off the bat? Workers' comp. So, with locums, you're 1099, right? You're an independent contractor. So any insurance is basically on you. You don't really get the benefits of workman's comp, disability, and health insurance and yada, yada, et cetera. It's all really just on you doing it yourself. I find fiscally, it's a better outcome if you put in the time and energy to kind of delve in and research it. How many state licenses are practical to hold at once? That's a hard question. So if you're doing telemedicine now, probably a lot. Depends on how much telemedicine stuff you want to do and how many states. Because like Teledoc, I think a lot of my colleagues that work for the Teledoc or something hold like 20 something state licenses, but there are also telemedicine licenses now that are separate. I hold New York, New Jersey, Texas, Wisconsin, and I just got Mississippi. So I have 5, maybe a little bit excessive. I haven't worked in Texas since 2017. And I live in New Jersey, New York, that area. One company I wouldn't work for. I wouldn't work for Comp Health. I mean, Comp Health and Weatherby have never sent me a job that financially makes sense to me. Their cut is just too deep. I think they just their margin is too high for that they take. So I probably wouldn't ever touch Comp Health or Weatherby. I do work with DNY, which is Team Health's locums arm. The big CMGs have a lot of issues, but I will say because Team Health was a publicly traded company and so was Envision before they got private equity buyout, they had to go through a lot of vetting. They had to go through a lot of lawsuits. And so their operational machinery is on point. Like you'll get paid every 2 weeks or whatever time frame, and you'll definitely get paid, and it'll come into your bank account. It'll be direct deposit, and that back office machinery is working. But you're also recognize that you're just you're a number to them. You're like one of 10,000, 20, 30, 40,000 physicians. So they don't care about you at all. They'll literally, you mess up, they'll be like, okay, get out, go to another site. Who wouldn't I work for? I haven't really encountered a terrible company. There are a lot of stories out there of different companies that have come out that they don't pay the docs on time. They don't do this. They kind of really bait and switch you on sites, and they sell you on one, and it's really something completely different. I haven't personally experienced that, but like I said before, I research my sites that I go to beforehand. I do a lot of investigation and reach out to kind of understand what type of environment I'm walking into, because I'd rather not walk into certain environments. I know what type of practice environments I like. Like, you know, you should kind of figure that out, I think, some level. Do you like inner city? Do you like suburbs? You know, different types of levels. Are you not okay with dealing with like VIP level patients? Then you probably shouldn't take a locums gig out in Long Island, or, you know, a suburb of Chicago, right?
Yeah.
Mhm.
Let me answer a couple of these too, and then I'm gonna back out. You guys can stay in for a few minutes if you want to, but we'll be meeting back in the main conference room in a second. But as far as workers' comp insurance goes, I think it's honestly state-based. When I was in Indiana, they were going to require me to buy my own workers' comp. That's like a state law, and so you kind of have to factor that into your cost of you know, what your pay is. And then state licenses. On that note, I know there's the state compact, which I have not used.
So I just used it, actually. I used Wisconsin to get Mississippi. It's actually pretty convenient. In the main group, I talked about my proposal, and one of that is that we probably should have a national license, but the IMLCC is a pretty convenient thing. But it doesn't have any of the big states if you're like a coastal person like me. So it doesn't have New
Yeah,
York.
it's mostly Midwest. But you know, on that note, I mean, I actually use it's called Licentium. If you know, it's a little expensive, but to be honest, I kind of enjoy it because I'm not organized enough. They will help you get your licenses and facilitate everything they can facilitate, but you still have to send you and this is for full licenses, so not a compact license. They'll still send you the things to do, like fingerprints and what do you call it? Get something done in front of a
Notary.
notary. Thank you. Thanks. Exactly. And so you end up still having to do all this work, but they do remind you, because if you have like 20 licenses, which is kind of a lot, then you have to pay the money to upkeep it. But they do remind you of when there's CME or something that's very state specific, and when to renew your licenses. So it does make that, if you really want to do like telemedicine or a lot of locums, it's helpful. I am going to jump out, and feel free to finish up in here. Thanks for joining, guys. I'm going to jump out to the main stage in a second, and then I think I made you a co-host, Raj, so you can stop recording.
Yeah.
All right. Thanks, guys.
How do I do that?
Oh,
Okie doke. Yeah, I guess with the last couple minutes, anybody have any questions or thoughts, comments, jokes? Having a good day, good Monday. I guess not. So there's only like 2-3 minutes left for the main stage. So I'll see you guys all back there. And thank you for coming, and thank you for your questions, and good luck.